good morning, and happy Monday to you. Happy Monday. Such a beautiful, chilly day. Little chilly, little chilly. Welcome. I have a great show for you this morning. As all of you know, you should know, it's Breast Cancer Awareness Month. And I have with me Dr. DeLorean Griffin, who is a plastic surgeon, and we're going to talk about breast reconstruction and maybe get into a few other things. Good morning.
Good morning. Thanks for
Okay,
having me.
get over here. Wake up and talk. Wake up and talk.
Too early.
Too
So,
early.
yeah, I don't get up this early. I'm just kidding.
I know you have surgery. You have surgeries early, don't you?
Yeah, yeah.
So, Dr. DeLorean Griffin. Now, first and foremost, where do you get the authority to talk to us about this?
Well, I have quite a bit of experience with not just breast cancer, but breast reconstruction as well. Most of my training, I did 5 years of general surgery, which allowed me to
Oh,
do quite a few mastectomies, lumpectomies,
really?
and breast conservation surgery. So when I subspecialized in the plastic surgery, I got to extrapolate on the reconstructive side, not only dealing with the mastectomy part, not knowing about the mastectomy part of it, but then getting the opportunity to restore the breast through breast reconstruction.
You know, it's such trauma in a way. Breast cancer, breast reconstruction. My grandmother had breast cancer back in the 60s, and she had a breast removed. That's the first time I had ever known of anybody that happening to somebody. And she was in her 60s, and she never did replace the breast.
Hmm.
I think she might have had something in her bra or something, but she
Right.
never did do that. Is that a old surgery? How old is it, or what?
Yeah, it's funny you mentioned the '60s, because prior to the '60s, breast reconstruction wasn't really a thing. It was in its infancy at best. So modern day breast reconstruction, as we know it, probably began around the 60s and 70s when we talk about the various methods that we use to reconstruct the breast.
What did they do before then? Do you know?
Yeah, yeah. So either the option was prosthesis, like your grandmother probably did, or they just had very primitive methods of reconstructing the breast. Actually, the first breast reconstruction was done probably in the early 1900s. They took a fatty deposit from somebody's flank or side and just put it where the breast used to be. And it
Oh,
didn't work. It
okay.
didn't work very well.
Okay. So I was just wondering if they didn't take something from somebody else, how people use dead body parts. But anyway, that's neither here nor
Well,
there. No.
yeah, yeah. Well, we'll talk about that too. That interestingly enough goes into part of what we do.
Okay, I wanted to kind of start off with that, with what gives you the authority. I want my audience to know that you have the knowledge. You're so young. You look so young. We know you're 70. No, I'm just
I gave
kidding.
myself a facelift.
You gave you. That would be funny, wouldn't it? Wouldn't
No.
that be funny? It's funny too because last month I was watching Frankenstein, the old Frankenstein,
Hmm.
on how they built the man and the head and the whole little things coming out the side of the head. But how long have you been doing plastics? Well, how long have you been a physician?
10 years now. I know it's hard for a lot of people to grasp, but yeah, I've been a doctor for 10 years. I graduated from Wayne State Medical School in 2007. Um, did
Wow,
8 year residency. Been in practice for some years at St. Mary Mercy Hospital in Livonia.
that's a great hospital. That's a great hospital. Well,
It is.
why don't we get right into it? What exactly is breast reconstruction?
Breast reconstruction is essentially restoring the breast contour through reconstructive methods after you've undergone mastectomy, and it kind of gives you some semblance of normalcy, not just physically but psychologically as well. You
Do
know,
you have to do any counseling of the ladies beforehand?
Absolutely, and the funny thing is that we probably see more of the patient than any other part of the multidisciplinary team. And that includes the breast oncologist, the surgeon, the chemoradiation expert, as well as a radiation, you know, radiotherapy expert.
Because you're like the last step.
Well, I'm every step. I'm uh,
Oh,
I'm 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 there from the beginning
and
of the
when you
process.
say the beginning, what are you talking about?
Well, I see the patient pretty early in their process.
I mean,
Usually
before the mastectomy?
before the mastectomy, once
Mhm.
they've been diagnosed, I see the
Oh, I
patient.
see.
Yeah. Usually I see him in conjunction with my breast surgeon who'll do the mastectomy, and then we'll plan from there what the next steps are. And then after that, after the post-op, it's all me. I'm doing well, for the most part. Some patients they'll get chemotherapy, radiation,
Right.
but me, I'm there every step of the way.
I know every patient is different. What are some of the anxieties that they may have about breast reconstruction?
Well, honestly, most of the anxiety is the breast cancer diagnosis
I
itself.
know.
They're
Oh, goodness.
still in shock from that receiving that news, and a lot of times they're not ready to absorb all of the intricacies of what goes into what happens next, and it's a lot to deal with. But I think that we have a very good team that allows us to present things in a way to the patient that'll kind of quell their fears and their apprehensions about breast cancer is a very survivable cancer out of most of the cancers. It's one of the cancers that if you catch it early, you have improved
Right,
survival. So
right, right. Well, like I said, my grandmother had her mastectomy in, I think it was 1965, and she lived on. That wasn't what she passed from.
hmm
Now, even back then, it was quite successful. Who is a candidate for breast reconstruction? Are all women who have a mastectomy or lumpectomy?
um, yeah, pretty much. Vast majority of women are candidates for some form of breast reconstruction.
Now, when you say some form, what do you mean?
So there are various methods that we use to reconstruct the breast. The first being, and the vast majority of women get implant-based reconstruction, which means that you're using an implant of some sort. Most of the time, it involves a tissue expander, which is a device that you fill with saline over time that allows you to stretch the skin out, over time, kind of like being pregnant.
So,
When
how long after the surgery? How long do they have to wait for the reconstruction to start?
um, most patients actually get immediate reconstruction, meaning,
Really?
yeah, yeah. So, and especially with implants, if they're getting a mastectomy, I'll come in right after the breast has been removed and start reconstructing the breast. And like I said, I work in close contact with my breast surgeon, so we get the best result. And most of the time, when he's removing one breast and may remove the other, I'll be working to restore that other
Really?
one. Yeah, at the same time.
This is amazing. If anyone has any questions, you could call us 313-868-4336, 313-868-0342, or 313-868-0351.
So
So, go
so
on.
yeah. So to continue, so there's implant-based
Yes.
reconstruction, which may have 2 to 3 steps. As far as what the patient needs as far as subsequent surgeries.
Hmm.
There's also what we call autologous-based reconstruction, meaning you're using your own tissue to recreate a breast.
That's what
And
I
that,
was going to ask. Do many, you said there's silicone? No, not silicone.
well, yeah, silicone is one type of breast implant.
It's funny. I'm pointing to my, you know, I'm just trying to imagine this right. I'm trying to break it down so everybody could kind of understand.
Hmm.
So, you, if they use some tissue of their own, where does it come from?
It can come from several places, and it all depends on what the patient has available. If you have a little bit more abdominal girth, then you can take tissue from there, and that would be in the form of what we call a tram flap, transverse rectus abdominal muscle flap. So there's either that or what we call a deep flap. Now, a deep flap is different from a tram in that you're disconnecting the blood supply and actually connecting it to a blood vessel close to your, where your breast would be. Most of the time, a vessel around the heart.
Well,
So,
you have some pictures.
yeah, I do, but I didn't bring any with me today. But
Oh,
if
I thought you
anybody's
had.
interested,
Oh, I thought you had some. The drawings.
oh, yeah, I have. I brought you some artwork. Don't worry,
Oh, okay, okay, okay.
and we don't want to interrupt the interview
Right,
for that.
right, right, right.
Yeah.
I just didn't know if you'd forgotten or whatever. So, I think that this
You
is
got you.
really, really so interesting. I'm kind of following you.
Yeah.
So you
So
build the breast.
yeah. So autologous reconstruction, you can either, you can take it from a lot of places. Belly, the back, your latissimus
So,
muscle.
so if someone gets it from the belly, there's it's like a tummy
You
tuck
get
in your
yeah,
stomach.
you get a tummy tuck out of it.
Oh, that's what
Yeah,
I.
you get a tummy tuck out of it. Yep. And I was fortunate enough to train with a phenomenal physician who does probably the best free tissue transfer that I can name, and that's Dr. Chai Seda at Beaumont, and he is a phenomenal surgeon. But you can take it from your back, you can take it from your butt, you can take it from your inner thigh, and it doesn't give you as much volume.
Okay.
But 90, I say around probably 90% of patients undergo tissue expander based reconstruction. So once again, you're using that device to stretch out the tissue. Once it's stretched out, you know, the patient at the same time may or may not be getting the treatment for the cancer itself in the form of chemotherapy and radiation. But
Can they
over
go
the
in and
time.
get the chemotherapy and radiation while they have this breast?
Yeah, so when you're expanding the tissue, you can get chemo through the expansion process. But with radiation, it's different because radiation causes irreversible skin changes. It can cause tightening of the skin. It changes the vascularity, how the blood vessels kind of behave in the surrounding tissue. So you want to, in those cases, try to get the patient all the way expanded to the point where you want to, the point where the patient wants to be from a size perspective, and then you can go in afterwards and put in a permanent implant. Most of the time, that's a silicone implant, like we were talking about.
Okay, okay. We hear silicone when it comes to
Hmm.
reconstruction, but just didn't know. I don't know why I keep doing this, but I feel so close to this. So, once do women usually get breasts the same size as they had before, or they decide to do something different?
Um, Most of the time, actually, women go smaller most of the time. Yeah, it varies. Some patients want to be the same size. Some patients want to be bigger. I say most women they come in with larger breasts and they say, well, this is where I want to be. This is kind of the cup size I want to be. I want them perky, and
Perky.
yeah, you especially when you do both sides.
When you
You,
say perky, that means standing
yeah,
up.
right, exactly. Yeah,
Because I guess after a while they do kind of droop a little bit.
yeah. There's so many things you can do to modify how the breast looks, to achieve an end result. That
So, how does the naked breast look after reconstruction and the person is getting better? And,
um, a lot of times you can, depending on what the patient has available and whether the patient's undergone radiation, a lot of times you can make it look like an actual breast. There's even nipple conservation um, uh, mastectomies that you can do to preserve your nipple if they're
Really?
an appropriate candidate. Yeah, you can keep your nipple. As long as the tumor size is smaller and further away from the nipple,
Nipple.
and you can get a clear margin around the cancer, then a lot of times you can preserve the nipple. Usually in smaller breasted women, it works better.
Well, I was thinking of the trauma, like you said, the call that you do have breast cancer, and then,
Hmm.
talking to, you know, that's quite a change in your life. That is quite a change in your life. How do you
Gotcha.
find the responses of many women? Do you get some who just totally panic, like I would, or do you get some who kind of? I think you give hope. It's like you give hope the way.
Yeah, you do. Like I said, it's all about restoring a sense of normalcy to the patient. When they're walking by and they're looking in the mirror, they want to, it doesn't look and feel like an actual breast a lot of the time, but in a bra, you know, most definitely you can appreciate the fact that it looks like an actual breast, and that's what you're trying to restore.
What's the feel of it?
Um, you know, it's interesting you say that. So if they've had radiation, that causes a lot of hardening and what we call capsular contracture, which is a capsule that forms around the implant. All women get it to a certain degree, but if you've had radiation, it can really intensify that. So some of the techniques we use, and this is what we're talking about as far as implant-based reconstruction, employs. You talked about using dead dead tissue. We actually do use cadaveric skin to help us. We use skin from a cadaver that's
Right.
has no cells in it. It's been donated. It's been processed. And it's called alloderm or ADM. Yeah, it's acellular dermal matrix, and we use it to not only get a better, you know, expansion, more natural appearing breast, but it also reduces that rate of capsular contracture over time. In some instances, it can cause more problems, but that's a rare occurrence. It actually integrates within your own tissue over time.
Does it?
Yeah, you don't see it, but it can act as an internal sling.
Uh huh.
And actually, what I've been doing is lately I've been wrapping the alloderm around the implant, and that allows us to do a few things, get a better, just more natural appearing breast, and actually speed, you know, um, hastens the recovery period. So
What?
there's that, and there's also fat grafting. So when I go back and I switch the tissue expander off of the permanent implant, a lot of times I'll do liposuction, collect the fat, and put it in the breast, and that kind of helps soften the breast. The
That's what I
radiation
was going to
changes,
ask
yeah,
about that. It seems like it would
and
help
you get free
some.
liposuction out of it too.
Yeah, but it's like six in one hand, half dozen in the other in a way, because you've lost something and
Yeah.
you're losing something else. But it is a good thing to, like you said, normalcy, give some normalcy. Well, what is the recovery time? Okay, we have first, the recovery time that you could stay in the hospital, because I know, like now they send you right out.
Um, well, it's getting to that point. I used to say, you'll be in the hospital one night per breast. So if I'm doing one side, then you'll be in the hospital one night, and then if you're doing two, then 2 nights in the hospital. But lately it's I think that the technique that I use has really decreased the amount of pain associated with it. You know, a lot of surgeons still do it. They go under the muscle, and that gives an extra layer of tissue. But if the patient has enough tissue, then I can go on top of the muscle without worrying about the implant becoming a problem, exposed, or anything like that. And really, that speeds the recovery time because you're not stretching out that chest muscle.
Oh, I
Yeah.
see, I see. So that's what I was wondering about, because back in the day, they gave you a little more time in the hospital once you had the mastectomy.
Right.
But I know things have changed so tremendously. Is a Will a woman be able to? Okay, she leaves the hospital after a day or two. What would be what would she have to do at home?
Well, they usually leave with a couple of drains, and
What's a drain?
so the drains are placed around the implant because you got a lot of fluid that's going to build up. It's just a part of having surgery. You create a space.
Oh,
You're
and
going.
it's like something that collects blood,
It collects blood.
mucus.
No, seroma fluid. So it's basically, think about just you burn yourself or any type of trauma that you have. You're going to have some fluid that invades that space. So that happens in all surgery. But when you create that space, you don't want that accumulating around the implant. You definitely don't want it accumulating around that alloderm because that'll affect how the alloderm incorporates. It may prevent it. So we really got to compress it very well. Those drains really help us get an idea of, how much fluid is there. When it drops below a specific level, we can take them out. And it's usually the first or second time I see them in the office.
Yeah, that was going to be my follow up. Was the office? When do you see them again?
Like I said, we're with them every step of the way. So I usually see them 5 or 6 days after surgery for the first time. Then we decide if we're going to take out the drains. We change the dressing, look at the incisions. The second time around, usually it's time to start expanding the patient. Interesting. So as far as recovery, what I've been doing is putting air in the expander initially, so that really decreases the amount of pressure that you're putting on the tissue. So I used to put saline at first. Now I put air and it just makes it lighter. So when they come back to see me the second time, I'll take the air out and start putting the saline in and just start the expansion process at that point.
Now the saline. That's what I was thinking about. Now that's is what?
Well, this is injectable saline, so
That's,
it's not a saline implant per se.
no, I wasn't talking about
Okay.
that. It's a liquid, right?
Yeah,
Okay.
yeah. It's a liquid that just allows us to expand over time. And you put in just enough that'll um, make a difference, but not cause the patient discomfort.
So
But you
how
can
is the patient usually? I mean, I know there's an exception to everything, but how is the patient usually feeling after that 6 days? Better? What?
Interestingly enough, most patients nowadays are complaining of very little pain.
Good, good, good.
And a lot of times when you're doing a mastectomy, you're cutting a lot of those nerves anyways, so you don't really have as much feeling in the breast that you would have previously. So most patients that follow up with me are in pretty good shape when they see me for the
So
first time.
I kind of want to get back to that radiation.
Hmm.
After they've done this and they have radiation, you say it can change the skin.
Right. Now, if they've had radiation up front, let's say they've gotten a mastectomy and they've gotten radiation and they want to rebuild their breast
Right.
after they've had a mastectomy and radiation, once those changes, you don't have anything in that space. The skin envelope is so tight that most of the time you can't do or I wouldn't recommend doing an implant-based reconstruction. Then you need to take some tissue from somewhere else, in my hands. Because, like I said, those radiation changes they can vary from person to person. Interesting enough, I'd say in African American women it's more pronounced. Um,
What is it? Our tissue or what?
you get a lot more hyperpigmentation, so you get a lot more darkening of the skin. Um, you see it more in African American women than Caucasian women or lighter skinned individuals for whatever reason. But like once you go back and you do that fat grafting, it makes a world of difference.
Hmm. Wow. It's such a process. Um, what type of screening for breast cancer should be done after reconstruction surgery? Because I'm thinking about this. I'm thinking about the fact, okay, you had the breast implant, you're getting your chemo. You get chemo afterwards, right?
You get chemo
Chemo
during most of the time
during.
during the process. Yeah.
Oh, okay. What if they see something a year or two down the line?
So with a mastectomy, you're removing
Oh,
all of
all
the
of it,
breast
all
tissue.
of it.
So in that instance, you really don't have much monitoring to do.
All right.
But that's not to say that you can't have cancer in that area um, at a later date. Usually, if you're going to have a recurrence, which is pretty rare, it's going to be at the scar and it's going to be visible on the outside. So, from a
Okay.
monitoring standpoint, you no longer need to get mammograms.
Okay.
Now, if you're doing obviously if you're doing just one side, then you need to do your regular screening on the opposite breast. Um, or if you're leaving behind some tissue, some like I said, those nipple sparing, you may leave behind a little bit of breast tissue. So in those instances, you may want to follow your normal screening guidelines.
Is there a typical time for surgery? I'm talking about how long it takes between the mastectomy and you doing your process. How long is a woman on the table?
So the technique that I use where I said like I'm constructing the breast while the breast surgeon is removing it,
Right.
that really shaves off a lot of time in the operating room. What used to take maybe 4, sometimes 5 hours, now it takes about 2.5 hours.
Really?
Yeah, yeah, because I'm working at the same time. Once he removes the breast tissue, I'm coming in and reconstructing that breast while he's removing the other breast. Um,
The
you know,
skill level is amazing. It's
we
amazing.
well we become a well-oiled machine over time.
Yes,
You know.
yes, yes. I mean, it is just amazing. I could see, well, you have such a comforting way about you. I could see how women would feel a little more comfort with how you sound and talk, you know.
Yeah, I hope so. It's
Well,
some
it's
things.
very important, though. It's
No, it is. It is. It
extremely
is. It is
important.
very important, and a lot of it it's not. It comes from within because they don't teach you how to be compassionate all the time in your training and your in medical school and everything else.
Right,
But you know, you just have to empathize with the women, and a lot of us have had family members who've gone
right,
through the same thing.
right.
So you want to treat your patients like you would your family members, friends.
So what if I have someone watching who has had a mastectomy but never got the reconstructive surgery,
Hmm.
and it's maybe been 2, 3 years? What do you have women who come to you after a time?
Yeah, occasionally. It doesn't happen very often. Um,
Can
most
anything be done?
absolutely. There's always something that can be done. If they haven't had radiation, they can get expanded, just like we were talking about before. If they've had radiation and that you can't expand that skin because it's so tight, they can undergo that. We could take tissue from somewhere else.
Is
Use the
that
fuse.
elective?
It's you know pretty much all plastic surgery is elective. Most plastic surgery is elective, including breast reconstruction. Nobody has to get it per se, but it's deemed elective surgery. But that's not to say that insurance won't pay for it, because that was going to bring me into my next point, is that
Okay.
the um, Women's Health and Reconstructive Act, and it was in 1998 that under the Clinton administration they mandated that insurance pay for not only breast reconstruction but any subsequent surgery that you would need down the road. That would include symmetry surgery. So if I
Symmetry.
right. So if I reconstruct one breast
Uh huh.
and you have a large breast on the other side, they'll pay for the breast reduction. Or if you have a small breast, they'll pay for augmentation.
Expansion.
Or yeah, I mean, just like you would get, you know,
Wow.
a breast augmentation.
I'm kind of fearful with the current political situation. I hope they don't take that away. You know,
That'd be quite the backlash if they were
it
to
would
do
be.
that.
It would be.
I'm gonna stay out of the political arena
Oh
right
no,
now, but
no. I was just. Of course,
but
my mind would go to that. You know,
yeah.
I'm just trying to be like
Hmm.
my people out there who are getting this great information, Dr.
Yeah, I
Brenda.
don't think it's going anywhere. And I think that is, as techniques improve, and technology improves, we're just going to have more and more phenomenal results.
Yeah, yeah. Have you seen? Have you have you did you develop your own method, or I mean, as you do it, a lot of times we do things and we say, "Oh, maybe I could do it like this." Have you
Right.
changed some things over time?
Yeah, I'm a very I call I'm a very adaptable surgeon. Some people are very stuck in their ways about how they do things. Me, I'm always looking to
You're
see.
flexible.
I'm very flexible, so I always go to I'll go to conferences and kind of pick up on things that work for other people, techniques. I in my training I took techniques from various surgeons that I gravitated towards, and you put together your own technique, your own way of doing things, and for now it works. But if you run into issues, then you want to know how you can improve upon that the next time. So it's always
Absolutely.
in my mind a very good thing to be an adaptable, flexible surgeon.
Yes, absolutely, absolutely. And it's so, see, women and men are different, of course, we know that. But for a woman, I used to wonder why, people did not feel whole
Hmm.
after they had the mastectomy. But I would say if they were afraid, I've heard, really, this is true. Psychologically, they were afraid their husband wouldn't care for them anymore. Things like that. Do you hear things like that?
I hear the concern, but I never see it from the husbands. Most of
Good.
the time, the vast majority of the time, the husbands are very supportive, and love their wives just the same,
Right,
no
right.
matter
But
what they
why,
go
I
through.
don't know. I just,
In my experience,
I believe in love is love. So, better or worse, isn't that what they,
for better or for worse, yeah.
yeah, yeah. So, as far as, do you see this even improving? I mean, it sounds like it's just amazing because women want to put on swimsuits again. Different things that they do. They want to live their normal life.
Yeah, and I think, like I said, we're getting to the point where a lot of times, in the absence of the scars, we're 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 making breasts look more and more like the real thing, and I think that only continue to improve.
Is there an age where you would say women shouldn't get reconstructive breast surgery um, after a certain age?
Well, there's no hard cutoff, but typically, in my hospital, we have a slightly older population that not doesn't always opt to get reconstruction. So they tell themselves that I'm too old for this, and I would say that most women are candidates for breast reconstruction in the absence of any grave medical conditions, see heart conditions or COPD. Most women are candidates if they want it.
If
But
they
it's
want
but
it.
it's perfectly okay not to want reconstructive. I had a 40 some odd woman in my office that just opted not to get reconstructed, and that was her prerogative, and I respected that.
Right.
I just wanted to.
What were there particular reasons, or
Um, yeah, I mean, she just didn't want to go through any more surgery other than the mastectomy, and she certainly didn't want what she would call a foreign body, in the form of an implant. And a lot of women feel that way.
and they could change their mind down the road?
Absolutely. 'Cause like we said, they can get reconstructed later at any time.
So you meet them. You meet them after they've been diagnosed.
Yeah, yeah.
So you
Pretty
meet
much
them
within
early in the
pretty
process.
much within the first couple of weeks after their diagnosis, and they've gotten the entire workup. Um, and then, like I said, I'm part of a multidisciplinary team, so we do tumor board on every Friday. So that's an opportunity
What
for
is
all.
that? Tumor board?
Yeah, it's just an opportunity for all of the specialists to come together and discuss a patient and come up with one comprehensive plan. Everybody's there. The breast surgeon, I'm there. The radiologist, the pathologist, the people that are, looking under the microscope at
Yeah.
the tumor itself, they're there. So radiation oncologist is there.
So, is there anything else you'd like to tell my audience about this type of surgery?
Yeah, I mean, just basically, there are a multitude of options when it comes to reconstruction. Um, and hopefully, I've kind of quelled some of the apprehensions
Yeah, I mean,
that
well,
maybe some of
you
your
have
listeners
that
may have.
manner. You have that manner. I see some people have been commenting on Facebook Live, but yeah, you have that manner that is comforting. It's nothing worse than a doctor who can scare you to death. And it has happened. It's happened to a lot of us.
It happens, and that just comes down to demeanor, and you know, in individuals. It's just how that's just human nature. But the vast majority of us out here are doing good work, doing
Oh,
phenomenal
yeah.
work, and we just want to advance the field and be informative as possible when it comes to these issues, because there's a lot of misinformation out there. There are a lot of myths, and we kind of want to
Yeah,
make sure
quell the
women.
myths. So, can we talk about some other plastic surgery? I mean,
Sure,
since we have a few minutes, a little bit of time,
sure.
because I talk to people who really think about it. They think about. I was talking to someone the other day, and they were talking about Friday, as a matter of fact, down at the medical school,
Hmm.
and they were talking about their eyes getting
Blepharoplasty.
ba- she had bags under
Hmm.
her eyes.
Yeah, yeah. It's pretty common. It's a process of aging. You can get the bags under the eyes, and we usually address that with blepharoplasty, which is basically removing that fat and then kind of reshaping your eyes.
Reshaping your eyes.
Yeah, most of the time, yeah, you make it. You know, people coming around, they have a tired looking appearance, and you just do you once you've done a blepharoplasty, it leaves them looking more refreshed. So,
Mm.
some people need upper eyelids, some people need lower, some
Yeah,
people
as
need
you
both.
age, and I noticed this, your eyelid up here starts kind of coming down a little
Hmm.
bit.
Yeah, there's
What
always something we can do. Oh,
what?
insurance will pay for that in some instances. If it comes down to the point where it's obstructing your vision, then
Oh, can you pretend? No, I'm just. Well, what about because you notice certain things. You look in the mirror. Some days you look like you're 85. Other days you look
not
like.
you.
No, please. My mother, she. Okay, let's talk about this. Um, the skin of African American women, and I have friends who are my age who are white, and their skin is so much different than mine. It's they have more crow's feet and all. Is that just family, or is that a thing?
It's cliche, but black don't crack. The melanin within your skin is actually protective of the sun. There's the UV rays that it causes a lot of the photo aging that occurs over time, and one of the added benefits of having melanated skin is, and it also has to do with the amount of collagen you have in your skin as well.
Or we
But
come with collagen in our skin.
yeah, we do, absolutely.
Well, some women get collagen in their lips, right?
Right, right. So I mean, that's you're talking about fillers and injectables. Yeah, it's
You
collagen stimulating
Well, you could
substance.
tell sometimes how you can really tell how some people um, they've gotten fillers in their lips.
Yeah, the best plastic surgery is the type that you can't tell happened at all.
Yeah, but you can kind of see it. And some people sometimes you should just I think, and because I was talking to someone about this yesterday, I said I'm just gonna go on and age. I'm just gonna go on and do it. I guess I don't know. I may be
Hmm.
knocking on your door in a minute, but your face starts to drop, and
Hmm.
you see it. You look at a picture of yourself. I say,
Yeah,
you
it's
know,
just
and
normal part of aging.
I know, but I have students who say, Miss Pamela, you still look the same. I said, I know I don't look the same after 30 years or whatever. But I guess they're growing older, so they see, you look at you. I don't know.
Yeah, well, my 20-year reunion is coming up on Saturday, and I've already seen some of those people.
From college or high
High
school?
school, yeah.
Where'd you go again?
I was Gaithersburg, Maryland, outside of Washington D.C.
Right,
Yeah,
right.
yeah. It's just interesting seeing how people age at various rates.
Yeah, I was class sponsor to the class of 78 who graduated from Highland Park High School. And I spoke at their 10th, their 20th, their 30th class reunion, and their 40th is coming up. I was their class sponsor, like I said. And I've watched them change. I've really watched them change over the years. So, what are the most common plastic surgery requests that you get?
Well, for me, I work with in a comprehensive
The
weight
team?
loss center.
Oh, you do?
Yeah, yeah, Michigan Bariatric Institute. So I work the one of the surgeons that does the breast, um, mastectomies. He also does weight loss surgery. So yeah, for me, I'm the guy that comes in and does all the skin removal, mostly tummy tucks, arms, thigh lifts, breast lifts.
Yeah,
Yeah, that's.
my daughter had a tummy tuck. She lost quite a bit of weight, so she had a tummy tuck and a breast reduction. Yeah, had to because it was playing on her back. A lot of
Absolutely.
Do you get that? Because a lot of women with very big breasts, it starts working on their back after a while.
Yeah, and then that's one of the criteria for insurance coverage. Yeah, and that it's amazing because breast reduction patients are some of the happiest patients once you've
I can
operated on them
see.
because that back pain is just like getting getting that burden of your having large breasts off your back. It's phenomenal how fast the pain goes away and how they're able to get back to their daily activities.
Oh yeah, yeah. I guess you're right about that.
Yeah.
What about a tummy tuck? How long does that? That a tummy tuck is really optional surgery. It's not the one you
Um,
have to have.
Not all the time. Actually, if you have a significant amount of overhang, you can imagine you get a lot of moisture trapped in there. You can get rashes.
Uh huh.
And if you're a weight loss patient in particular, even if you've lost a significant amount of weight on your own, insurance will cover that lower portion, the penniculectomy part of it, so the lower part of it. Most of the time, you have to pay for the skin, the muscle tightening, um, which it's where your six pack muscles separate. And they put it back together, called application, and then moving the belly button as well. That's deemed cosmetic.
Moving the belly button.
Yeah, that's part of the tummy tuck. Yeah. You're pulling all the extra skin down, so you have
Right.
to make it
Oh.
for your belly button to come through.
Oh, so you pull that down,
Hmm.
and you keep your belly button though.
You keep
just
your native belly button,
okay,
but you're
but you
making it
change where it was.
right. So I mean, you know, that's deemed cosmetic. But it's called an abdominoplasty. That's probably the number one procedure I perform.
Oh, now, yeah.
In
Oh,
some
that's
combination.
interesting. That's what. That's interesting. That's really really interesting. What about butt lifts?
Well, there's
No, the reason why I asked, somebody gave a speech on it at the medical thing the other day.
really.
They were showing, there are dangers in it if you don't get it done at the right place.
Well,
And
this is true. I think that there's a lot of kind of misinformation about how, as far as the terminology when people talk about butt injections.
is it an injection?
Well, the most dangerous thing is having free-form silicone injected into your buttocks by a non-medical professional, and that's usually done and you know,
Yeah, I heard about that, and I heard
hotel
that that can
rooms,
be
and
very
yeah,
dangerous too.
yeah, it
How
can
do
be
these
fatal.
people get a hold of that stuff?
I couldn't tell you, but luckily I think that the information is getting out of there. I'm seeing less and less of it, but once it's done, and it's a very difficult problem to correct. If you, most people have
Have you
complications.
ever had anyone who's gotten one and they came to try to have it corrected?
Yeah, and most of the time, all you can do is just remove what you can, and sometimes they get infected, silicone beads, and you have to drain and abscess. But yeah, um, it's a big price to pay to not have it done the right way.
Well, what about breast implants? Say if I wanted to be well, a 50. 50.
Um, for me, I typically I don't like
No,
to put in
uh,
extremely large breast
right.
implants, but most of the time it can be done safely in the same manner that we do breast reconstruction.
So what's the recovery time for that? If somebody wants to be a little bigger.
It's pretty fast. Most of the time, the patients go home the same day. Um, you're not doing a whole lot of dissecting. It depends on if you go under the muscle or above the muscle, same way you do breast reconstruction. So it's faster, I think, in my hands when you go above the muscle, and you get there are trade-offs whether.
Well, I wanted to know, do you ever have patients who want to look a certain way that is not quite like the way they look naturally?
Right, and I say it's very important to set expectations up front when you're dealing with any type of plastic surgery. Um, you got to manage those expectations up front because there are people that will coming come to you wanting things that are just not achievable, and then you got to really put those risks in the forefront, and and be very candid about what you're capable of doing, capable of achieving, because that's pretty much the only way you're going to have a happy patient in the long run.
My gosh, well, you talk about psychological things. You have to get people to love who they are and
Yeah,
develop.
and a lot of people. There's a lot of stigma when it comes to plastic surgery. I think that you know everybody has insecurities about something regarding
Tell
their
me
appearance,
about
but
it.
it's not a overall
Overriding thing.
overriding global insecurity. And I think that if you're able to change a few things, then really, what I find is that you're taking confident women and making them more confident. I wouldn't consider them
Okay,
insecure.
my face sags. If I had a plastic surgery on my face, a facelift, what would you have to do?
Um, well, that's everybody needs different things. When you do a facelift, most of the time, a lot of times you have to address the neck as well. So you're doing a neck lift with it, but it's the same scar. You basically put a scar in front of the ear that goes around the ear. You take um, the muscular aponeurotic layer. Basically, it's a structure that allows you to
Skin back?
pull the skin back and all the tissue back in the proper what we call the vector to meet the patient's needs, and that gives you long lasting results.
How much younger can it make you look?
Varies from person to person, but on average I say 10 to 15 years a lot of times.
You're kidding. That would be so crazy. Here you are, certain age, a woman of a certain age, and all of a sudden you look a certain age, a different. It would be just so drastic and different. And then what about the scar?
I mean, scars are part of any surgery.
Should we have to grow a beard like you got on the
No,
side and cover up the?
no, I can't grow the full beard anyways. Somebody wanted to add me to beard gang. I'm not quite there yet. Maybe when I'm 45 or something.
I know, I know.
But no, scars are a part of surgery, and most of the time we place them strategically um, to where you can hide them the best way possible, and it's all about how you close as well. And, but some, some people, some patients they scar better than others, and it's out of your control how they
Well,
heal.
well, a facelift to me, that costs a lot of money, and that's out your pocket, isn't it?
Yeah, and it's a price a lot of women are willing to pay. You know,
Do men?
men can get facelifts as well.
Uh,
Yeah,
I
you
know
just
of.
got to be careful because you don't want to pull their beard back into their ear, and then you get hairy ears.
God, I never thought about that.
Yeah.
Because I know of some men who are entertainers, and I've seen them over the years, and you could kind of tell. I mean, you could tell. Say, no way he
Well,
should be looking that young.
I said it before, and I'll say it again. The best plastic surgery is the type of surgery you can't tell happened at all. Sometimes you're going to be able to tell because you knew the patient
Well, if a
beforehand,
man
but
is 80 years old, to me, if a man is 80 years old, he should not look 50. Seriously, I'm serious about that. Because I know of this man, he's about 80 years old. He looks great.
some people age.
I mean,
Some people age
seriously.
well.
No, well, no. You could tell his face look a little bit different. The teeth are different. And some people add teeth to their whole process too, right?
Absolutely.
My goodness. Do you ever get people who want larger lips?
Yeah, yeah. Just like we talked about using Juvederm, the filler, the fillers to enhance your lips. Um, sure, I get that from time to time.
Well, I'm so happy that we were able to get on and talk about breast reconstruction. I want to just momentarily go back to that
Hmm.
and tell people if you haven't had it, you should just check it out, see if you could get it, you
Yeah,
know.
like I said, most people are candidates. Um, absolutely, absolutely. Anybody that has questions can they can go on the website.
What
Oh, and
website?
Wednesday is official breast reconstruction day, breast
Really?
reconstruction awareness day, broad day.
Oh, wow. Yeah,
Yeah,
so
so
we're ahead of the game. We're ahead of the
and I brought
game.
you some M&Ms here.
Oh, God. Thank you. Thank you.
They're
2 bags.
just don't eat them before you take the number down, so you know how to reach me.
Well, I know. Oh, the number is on there. Is this the number to the?
That's the number in my office. Yeah.
Okay, the number to Dr. Griffin, and that's Dr. DeLorean Griffin, 734-655-3000. Even if you want to go in for a consultation.
My door is always open.
Yeah.
And you wanted to see some artwork too, right?
Yes,
I
this
guess
guy is phenomenal. You are.
I'm all right.
No, it's amazing.
Well, we got something for you.
What is, oh my
You recognize that
God.
person?
Oh my God. Everybody. He drew me. He drew me. Oh my God. Oh my goodness.
So yeah, put that on your
Oh,
refrigerator. Where you,
I'm framing that. Oh God, look at those teeth. Oh my gosh. Oh my goodness. Thank you so much.
well,
Oh,
it's a debt
anyway.
of gratitude for having me on the show.
Oh, but this was such valuable information because right now I'm going to tell you on the woman's side of things, they are getting so much more thorough. You go, you have your mammogram, they will call you back in the next day or so to tell you we want to look at it again. You may not have anything, but that ultrasound, or they may want to do an ultrasound. It seems like they're really, really on top of it. And I think a lot of women are scared to get mammograms. It's just like some of the men who are scared to get mammograms, and then they end up
For prostate exam. Yeah.
with prostate exams, right? But you got to see what's going on with yourself.
Yeah. I think everybody should take command of their health. Um, you know, uh, it's just a necessity if you.
If you want to live.
Yeah, I think that, there's always that distrust in the medical community, but I think informed populace is a healthy populace.
Right. And you see everything, you can take care of it because it doesn't matter how much money you have. If you don't have your health, you have nothing.
That's absolutely
You
true.
can't take care of your kids. You can't go to the party. You can't do anything. This is just, this is such important information, Dr. Griffin. Just, thank you. I can't get over this. My goodness. Oh my God. Okay, everybody. I'll see you Friday. We're going to have a great show Friday. Remember, Wednesday is Breast Reconstruction Day.
Yep, breast reconstruction and awareness day.
Awareness
Yep,
Day. Okay.
bra.
We pulled your coat, as they say back in the day. And I'll see you Friday.